Welcome to Stand Up for Doctors. I'm your host, Kim Downey. Thank you very much for joining us. This channel is dedicated to amplifying the voices of doctors, other healthcare professionals, and patients as they share their unique struggles, triumphs, and passions. My mission is to build connection and create advocacy for healthy doctors, driving positive change that benefits both doctors and patients. This is a space for everyone who cares about the future of healthcare. If you appreciate this content, please like and subscribe now. It really helps the episodes reach our target audience. And today I would like to welcome Dr. Ronen Elefant and Dr. Marco Fernandez. Thanks for joining us today, Ronen and Marco.
Thanks for
Thanks
having
for
me.
having us.
You're welcome. And by way of a brief introduction, I'll have you introduce yourselves further. Ronen is an acute care surgeon, aviation surgeon, entrepreneur, expert witness, innovating healthcare economics and transparent pricing models. And Marco is an anesthesiologist and president of Midwest Anesthesia Partners, an association for independent medicine. He's a member of the Coalition for Patient-Centered Care, among other hats that he wears. I couldn't list them all. And today we'll be talking about how you're both doing innovative things to take medicine back for the greater good of doctors and patients. And we really need to amplify these messages. And I'm actually in conversation with Olivia Morris. I don't know if either one of you know her yet, and we're figuring out how we can do this on a grand scale. She's in Ireland, and just connect all of you who are doing really incredible things to take medicine back for doctors and patients. So, thank you for all that you're doing. And I always start by asking what you'd most like our audience to know about you as we begin our conversation. Ronen, would you like to go first?
Sure. Thanks. Thanks for having me, of course. I guess what I want the audience to know most about me is that my passion and what drives me in all my endeavors in the medical field is bringing back the patient and physician relationship. I think that there's been a lot of different actors within the healthcare space that have come in and tried to put a wedge between us. And all my efforts, and we'll get into it further during the podcast, stem from that desire to bring the patient-doctor relationship to what it used to be, 50, 60 years ago, just direct patient care.
And thank you very much. And that resonates so strongly with me because I've had plenty of patient experience over the last few years. So I'm all about that. And that's why I'm doing this work. And I love what you're doing. And Marco, what would you like us to know about you? Besides the fact that you know Michael Hirsch, my physician coach.
Yes, he's my BFF.
Yeah.
Thank you for having us, Kim. I'm just a full-time practicing anesthesiologist, and before the pandemic, I was doing what every other physician was doing, just trying to be able to provide the best care possible until we had private equity come knock on our door. And then after that, we had a few entanglements, and we ended up trying to find support through our legacy societies, and we really couldn't find any at the time. So we ended up creating our own organization to help with advocacy and to help physicians providing tools to try to stay independent or regain your independence if you lose it.
hmm Yeah, that's great, and that's so important. And I also like each of you to share a powerful story. What is your why? Ronen, would you like to?
Um, I guess I'm just driven in general, and I'm very passionate about anything that I take on. And so, again, you'll hear throughout the podcast when I tell my story, is that I kind of go to extremes when it comes to whatever it is that I choose to do. So, whether it's in medicine or aviation, I want to push the boundary. I want to think outside the box. I challenge norms. Um, that's kind of how I live with every aspect of my life, whether it's good or bad. Sometimes it's not so good, but there's a lot of good that hopefully will come out of that.
Well, and you can share what you'd like to about your story now. This would be a good time.
Sure. So I guess the way I ended up here and doing the things that I'm doing is when I was coming out of fellowship, my full-time job wasn't starting for a couple months, and I was a poor fellow, needed to make an income, but I also wanted to have some time off after 15 years of training. And so I started by doing locums. And for those who don't know what that is, it's basically just moonlighting at various hospitals. And I was going around to different hospitals doing that kind of work, just a couple days a month, to make the income. And even though I started my full-time job a couple months later, I continued doing the locums work because I had enough time. You go as a fellow working 120 hours a week to all of a sudden as an attending 40 hours a week, and I had a lot of time on my hands. I wanted to operate as much as I could. The money was good. The places that I worked at felt like I felt appreciated at those places because they had the need. So there were a lot of good things that came out of it, and I quickly realized that I really enjoyed that type of work, and I wanted to continue doing it. I asked my wife if I can do that full time, and she was worried that there wasn't much stability with it, and you don't know, if there's going to be a job. It's sort of like month to month, and at the time, I wasn't ready to make the jump. Now, at the same time, in order to get to these facilities, I had kind of gotten back into aviation. I got my pilot's license when I was 19, but I wasn't flying much, obviously, throughout my medical career as I was training. And in order to get to some of these facilities that were not easy to get to by any means, some were like a 10-hour train ride. I would rent an airplane and go with an instructor and kind of get my skills back up to the point that I was able to start flying myself. And then I just bought a small 4-seat piston airplane, and I flew it all over the East Coast from Connecticut to Florida to South Carolina to Pennsylvania, quite a lot. And I just had a great time. It was, again, just another good reason to go work somewhere else because it allowed me to fly. So I was gaining a lot of aviation experience that I wouldn't normally get if I worked locally. If I worked locally, I would maybe get a couple hours a month, but I was able to do like 200 or even more hours per year. And that's how I ended up where I am now in Pennsylvania. I'm working as a trauma surgeon in rural Pennsylvania, and I fly here. From Connecticut. I still live in Connecticut. We enjoy living there, and there's a bunch of reasons that we want to stay there. And again, I enjoy the commute to work. It gives me my peace and my quiet. It's about a 45-minute commute. I don't do it every day. I come here for a few days at a time, and then I go back home for a few days as well. And the concept for the business that I'm creating really came about 10 years ago when I started doing this, but it didn't materialize until now, where I realized, you know what, I have enough experience with this doing it on my own that I want to share that with other surgeons and allow this sort of lifestyle design to be shared with other surgeons. And I realized, with the help of some great networking, mostly through LinkedIn, that a lot of other surgeons are interested in doing this kind of work and similar work, where they would feel appreciated and they feel like they get what they're worth, and they make up their own schedule and choose when to work and when not to work, and not be, an employed physician where they feel like they're just part of a factory. And yeah, so that's sort of my mission. And now I'm building a company called 𝗥cie has Surgical, and we are going to be offering cash pay, all bundled surgeries to patients at various ASCs. We're going to be operating in Wisconsin next month, and then opening up operations in South Carolina and locally for me in Connecticut as well. But it's open to other surgeons and other specialties. We're going to start with general surgery, and that's modeled after the Surgery Center of Oklahoma, where again, I think that we've seen the model work, where transparent pricing really brings back that patient-physician relationship, and it ends up being cheaper and better for patients and physicians. It seems like everybody is just happier with a direct relationship.
Well, I think that's fascinating, and I love having the two of you on together because you generally don't do surgeries these days without an anesthesiologist, right? So you two rely on each other for your work. So, Marco, anything that you'd like to respond into what Ronan said, and then share a story of your own?
Sure, Ronan, sign me up. You need a gas passer. I'm there.
Okay.
I actually had spoken to Adrienne Townsend. She told me about you and what you're doing, and that's exactly what I asked her. I go, you need an anesthesiologist, sign me up.
Yeah. No,
Fantastic.
I always envision, filling up the airplane with a whole bunch of doctors, right? Like just make the cost of the flight cheaper by bringing, as many people as possible on the flight.
Fantastic. Yeah, well, we definitely need to talk offline.
Yeah.
Well, for me, aside from, the whole thing with physician independence, on a personal note, I also got to experience it on the patient side, which which made it my burning platform after my experience. So my mom was diagnosed with inoperable liver cancer a few years ago. And we went through the whole, what everyone goes through in terms of uh, getting chemotherapy, seeing your physicians. And I felt a little bit of comfort thinking that I could navigate the system and she wouldn't suffer much. And I was sadly mistaken. She did receive care at my hospital and she got great care for them from the physicians, but from a nursing standpoint, it was not very good care. And I can't say that it was due to nursing competency. I think it's just there's not enough nurses. She was in the hospital for about 8 days, and after the first night, I went to go see her, and they were cleaning up the floor, and I asked my mom what happened, and she said she had been calling for a nurse all night. She had to go to the bathroom, and they never came into the room to check on her, and she didn't make it to the bathroom. She basically soiled the floor. And then a few days later, I came in to check on her before surgery, and she had been suffering all night with pain. And I asked the nurses, when was the last time you gave pain medicine? They were like, no, we haven't given her any pain medicine. She's been comfortable. And I said, my mom's in agony. Can you please give her pain medicine? A few days later, we realized we couldn't take her home. The hospital had a hospice center in the top floor, and I thought it was part of the hospital, but it wasn't. It was a separate entity. And by the time she finally got up there, she did get comfort care, and so we were relieved. She wasn't suffering anymore. But after a couple days, my sister, I gave her a break from her shift, and I was in the room with my mom, and someone came in and gave her medicine by mouth. And at this point, she's in hospice care, and I asked the nurse, "Are you sure you have the right patient?" She stepped out for a few seconds, came back in, and said, "Yes, I do." We proceeded to give her the medicine, and she ended up aspirating. So she was coughing all night. It turns out it was the wrong medicine, wrong patient, and they never gave her any pain medicine that night. I had confronted the leadership afterwards. They apologized. They said it was an agency nurse. So she wasn't even a hospice nurse. It was just, they just needed a warm body to come give care. And I did speak to leadership about trying to prevent this from happening to other patients. My sister wanted to talk to the press and talk to a lawyer. I said, no, we are here just to spend time with our mom, and we're going to mourn, and we're not going to worry about anything else. And for me, it was heartbreaking. And later I find out that the hospice center was owned by private equity. And I don't know how much that had a part in it, but I just felt that we were nothing more than a number. And the nursing shortage, along with physician shortage, is just a symptom of the problems that we're having in healthcare. And our organization is not just trying to deal with the symptoms, we want to deal with the causes of all of it. And that's why we created what we created, and we're trying to coalesce the efforts across groups to try to create whatever impact we can.
Well, that's a very sad and powerful story, and I've had 5 surgeries in the last few years, and the first one, without getting into detail, was like a night of horror from the time I walked in till the time I wheeled out. And so I understand what you're saying, and that's one of the things that surprised me most in these spaces is I would have thought before I was doing any of this work that if you were a doctor that you would get good care, your family would get good care, right? That you would just be able to oversee all of that. So it must be so incredibly frustrating knowing the things that you know and still not being able, to make a difference sometimes. I'm just so sorry, right, that you had to, and that's another form of moral injury, I would say, right? So, yeah, and that's why we have to change, stories like this, and it doesn't matter if you're a doctor or who you are, right? Like patients deserve good care, and you know that from both sides. Um, Ronen, if there's anything you'd like to respond to what Marco said, and if you want to tell us a little more about what you're doing, how you're doing it, how can we
Yeah.
let more people know about it?
So Marco, I'm sorry about your mom, and I work in a hospital setting, and I'm trained as an ICU doctor, and I see that all the time as well. And the nursing shortage is nationwide. We have that. In fact, just today when I was walking through our ER, a couple nurses were asking me if there's other jobs that they can have with our department because they just have way too much of a load on their plate. They walk in the morning and they're already behind. So it's definitely not sustainable. And I'm not sure what the solution is, but I'm sorry that you had to experience that as from the patient side. And regarding a little bit more about my business, I don't want to leave trauma surgery. So again, I'm trained as a trauma surgeon, and I have a training in general surgery. So the things that I'm doing as a business owner is more on the elective general surgery side. And I don't want to leave trauma surgery altogether because once you leave trauma surgery, you can't go back. You can't apply and say, like, I haven't done trauma surgery. So I just want to reduce the time that I'm doing it again, just because it is hard. I've been doing it for about 10 years and it gets to you, taking call as much as I do. Being up 24 hours or being woken up multiple times in the middle of the night, like that's again not sustainable. It's something that I thought even up to a couple years ago, thinking, okay, you know what, I'll be able to do this till I'm 60, but I'm 45 and it's already getting to me. I don't bounce back like I used to from call, and it's just way too hard, and I need to reduce the number of days that I do that kind of work. And so I want to have a little bit of a general surgery practice in a way that I've been doing the inpatient work, right? So traveling to different locations and having other surgeons travel if they want to, or not travel, right? So the way our business model works is we just go where the patients are. So if there's a patient need in a certain location, we partner with an ASC, and we tell them, like, hey, this is our business model. Is this something that we can do at your facility? We'll bring the surgeons, we'll bring the patients. This is what we'll pay you for your facility fee. And so far we've gotten a really good response from a couple centers, and there really shouldn't be any reason why we can't do it with other centers. So over time, we'll go based on patient needs and maybe even destinations that patients want to go to for their surgery. So one of the places, like I said, we're going to be operating in South Carolina, in Charleston. So patients that in the past may have traveled to Surgery Center of Oklahoma, if they choose to come for a weekend and have their surgery on a Friday in Charleston and have their family stay in Charleston, if that's a more attractive option for them, it gives them options. And again, I'm a firm believer in free market principles in healthcare. And at the end of the day, we got to give the choices back to the patients. And this is the way I think it should be done.
Mm-hmm. And I love that you're modeling a way to make medicine sustainable for you yourself, because we need doctors, and some doctors leave medicine altogether, right? If they got tired or burnt out and didn't feel like they can imagine taking call the way you do for another 15 years. That just might seem some unsustainable to some doctors, and they might leave. But I love it the way you're thinking outside the box, because we need doctors, and this way we aren't losing you. You're practicing somewhat in a different way, and I think we need to spotlight all of these options for doctors. So can you share, say there was an anesthesiologist such as Marco that would like to get involved, what would they actually do? How would they reach out to you or?
Yeah. So we launched a website a couple weeks ago. It's acessurgical.com, ACES surgical.com. The name of the company is ACES National Surgical Team. And there's a way to reach us and submit your CV, whether you're a surgeon or even patients can find us there, or ASCs. So we sort of have intake forms for all three, because what we're doing is we're connecting ASCs with patients and with physicians. And then we're working out the logistics of getting the doctors all around. Now, it may not be by private aviation to start. We got to grow into a network, but eventually, if the economics of it work out in such a way that we can build a network where private aviation would be worthwhile, then we'll explore that. But you'll get a sense of, again, the company is such that it doesn't fit into a certain boundary, right? So we can really go anywhere, and that's what there's like an aviation theme to it, that patients are no longer bound by where they are, by their geography, right? So like if patients are in an area that has poor access to healthcare, they can travel, or maybe we can even travel to them.
Yeah, that's great. Marco, if there's anything you wanted to say or ask in response to Ronen, and then I'd like you to share more about your work. And you do so many things. You can pick whether it's the Coalition for Patient-Centered Care, or whatever you want our audience to know about what you're doing.
Yeah, from a practice management standpoint, we're very much doing what Ronen is doing. And just today we decided we're going to schedule a meeting to do out-of-state locums. So about a little bit over 18 months ago, our practice was based, our subgroup was based in a hospital, but then the hospital terminated us and we pivoted, and the most of us stayed together, and we started to provide services to all the community ASCs. So we already had long-standing relationships with the surgeons, so it was easy for us to fill the gaps for whatever they needed. And we have long-term contracts with them, and we have with hospitals. That's about 20% of our business. We do locums work for hospitals. So if they need call coverage or they need cardiac, we do that. But now we're growing, we're trying to explore opportunities outside the state. So that's from a practice management standpoint. From an advocacy standpoint, we've been pretty busy. At least the past 6 months, been meeting with a lot of organizations, met with the AMA, and I was just in DC with the American Economic Liberties Project. They have a campaign going on to break up big medicine, and they had an anti-monopoly summit a couple of weeks ago. Very well attended, very well organized. You had some pretty big names in politics. They had economists, unions representation. They had a standing room only audience, and about 30,000 folks did register virtually. And we are partnering with them. We're working very closely with them. There's a couple of health policy fellows that are working with the Coalition for Patient-Centered Care, and currently we're meeting with different state AGs on trying to strengthen their corporate practice of medicine laws. Just try to make sure that physicians stay independent and you don't have corporations trying to practice medicine. So we're pretty busy with that. We've been doing that for quite a while. And going into 2026, we're trying to ramp up efforts with the AMA and other organizations as we head into the 2026 elections. So we'll see what kind of impact we have. But our network with consumer protection groups is growing and strengthening, and we're trying to get physicians to participate however they can and join any group possible. But one of the things that we did talk to the AMA about was trying to find ways to be able to partner. We don't want to compete with anyone, but I think it's important that we take this whole financialization of healthcare, try to take it head on and not just deal with the symptoms of burnout and scope of practice and prior authorization, which the AMA and other organizations are doing a phenomenal job. But I think we need to do a little bit more to address the causes of all of this.
Yeah, I love
If I can
that. And
comment
your
on that, Sorry,
Go
Kim,
ahead, Ronan.
if I can comment on that, but I'm a firm believer that the reason why so many physicians are burnt out all stem back. If you like look at where they come from, it's all because of the insurance model of healthcare and how we pay for healthcare. And again, I think if you bring back that physician-patient relationship and use healthcare or healthcare insurance in the way it's supposed to be used, which is for catastrophic care, um, patients and physicians are going to be much happier.
Yeah, I agree. But I think that that same playbook that's being used by insurance companies is also being used by private equity and also hospitals and big pharma. The vertical integration and the vertical power they have due to consolidation is very overwhelming and hard to chip away at. You go speak to your legislators, and there's a lot of conflicting interests that'll follow you through the door. You go in and you talk to them, and yeah, they're interested in changing the system, but then you walk in with someone walks in after you, big name lobbyists, and
Yeah.
it's so hard to compete with it. I think we have more power than we think. It's just a matter of trying to get all of us on the same page.
Yeah, and the truth is, I think we have to start, back to the basics and start with the system anew. It's not going to be about lobbying Congress to change, this piece or that piece. There's going to be the bubble's going to burst at some point, and we're going to have to start from scratch. And again, it goes back to free market principles in healthcare that you can't run away from, right? Like all these fixes that we're trying to make are just band-aids to a problem that we've created over time that started, back in World War I, World War II, right? And employers being involved in healthcare and the government being involved in healthcare and hospitals. And at the end of the day, when you have the direct relationship between the physician and the patient, then a lot of those things go away. But it will take a lot of time and effort. I don't know if it's an echo chamber that I'm seeing on LinkedIn with the people that I'm connecting with who are within the same space, but I'm hopeful that within the next 10 to 20 years it'll change for the better. And I'm seeing, sort of a wave of this, of people who think the same.
Agree.
Yeah, I think so. It has to change. So I don't know if you guys are familiar with the two loops model. So I'm involved with the Healthcare Reinvention Collaborative, and what they would say is like systems, there's a rise and a peak and a collapse, which you could say is happening to our healthcare system, and then something else will come, and replace it. But you need a bridge, right? If our healthcare system totally collapsed, that will be a disaster, and so many people will end up dead. So, do you guys have any? I know it's very complicated, but is there anything that stands out in your mind what we could be doing to bridge as the old system collapses and we need to rebuild something to replace it?
That's a very good question. Yeah, I don't, it's so complex, and everyone will argue about a possible solution. And for me, it's not so much of coming up with a solution as opposed to just bringing people together. I think, the AMA wants to be the voice for medicine when not everyone agrees or is a member of the AMA. And I think they need to be supportive of folks like us who are trying to do things a little differently. So it has to be a two-way street. And then once we come together, then we can figure out how to prioritize things and try to build that bridge that you're talking about. And for me, the number one thing would probably start with stop cutting our pay, stop cutting our reimbursement, because then we're not viable as independents anymore. But if they at least stop doing that, then we can at least survive for a little bit and then figure out what would be the next steps.
Yeah, and again, I think this is where the insurance model is the real problem, where the government is the biggest insurer, and at the end of the day, us doctors are dependent on whatever it is that they choose to pay us. So there's a lot of physicians who are just saying, you know what, I'm just going outside the system, and that's why I think part of the answer in that bridge that we're looking at is direct primary care physicians who are just going out on their own and saying, I'm going to take a panel of patients, I'm going to cap it at a certain amount, you're going to have access to me, and patients paying out of pocket for routine care. We've seen costs of healthcare go down when things like that happen. So we've seen that in plastic surgery, in ophthalmology, and even direct primary care. At the end of the day, it's cheaper. And also patients themselves are taking ownership of their health, right? So another thing that happens with the insurance model is patients rely on the insurance to sort of guide them in their healthcare journey. And I think nowadays, especially after COVID and with just the information that's out there on the internet where people can do their own research, and obviously it's not for everybody. There's a subset of the population that, is not as educated on their own healthcare, but hopefully things will change. And like I said, COVID, I think, made a lot of people skeptical about the healthcare industry and physicians. And obviously it's bad, but there is some good to it. And patients taking ownership of their own healthcare is the good thing that came out of it.
Completely agree. Direct care would be great.
Mm-hmm. Yeah, and I think part of what we're saying too is educating patients, and patients need to understand all of these things. And Dr. Amna Shabir has said that physician advocacy equals patient advocacy, right? And if we advocate for our physicians, then they can advocate for us because we all want the same thing, as Dr. 𝗙𝗲𝗄𝗻𝗃 would say, is the best care for the patients. So patients just need to understand that it's not all the doctors, things with the doctors going on, right? There's a lot of limitations and loss of autonomy that you all are experiencing, and they have to understand that. So we are absolutely, I'll connect you with Olivia Morris, and we're going to be working on connecting all of you who are doing these really important things and just to learn from each other and scale it.
That'd be
So,
fantastic.
yeah, so as we wind down, Marco, is there any final words you'd like to share for your colleagues and how our listeners can get in touch with you?
We have our website, our Association for Independent Medicine, and we're trying to do whatever we can to partner with folks in medicine and outside of medicine. And as you said, do our best to educate not only physicians, but patients as well.
Okay, that sounds great. So if our listeners want to get in touch with you, they should go to the website, the Association for Independent Medicine?
Yes.
Okay, sounds good. And Ronen, do you have any messages for your physician colleagues and how you would like our listeners to get in touch with you?
Yeah, Marco, I share your sentiment and I appreciate you, advocating for physician independence. And like you mentioned before, I think physicians don't realize how much power they can wield. And we really can make a difference. And it's time for us to put our foot down and say, like, this is not sustainable and we're not doing this anymore. At the end of the day, we're the ones taking care of the patients, and the bureaucracy has grown that just adds complexity and cost, and we need to reduce it. It's just this is not the way to practice medicine.
Mm-hmm. Absolutely. And would you like our listeners, would they be getting in touch with you through the acessurgical.com?
Yeah, acessurgical.com. There's a number there. There's email. That's the best way to reach me.
Okay, great. And speaking to what you're saying, so I remember when I was working in the nursing homes, and that's when the EMR came out and things got so bad, and then the therapists were just asked to do more and more. And I actually said, because I was working per diem, I wasn't there all the time, and I was like, why can't you just say no? Like, they can't fire all of you, but I don't know, but they were afraid, or who knows if they would have, because they would think that they're replaceable, but there's always a physical therapist shortage as well, right? So
Yeah.
sometimes I would want to say that to doctors too. Like, why can't you just say no? It's like they can't fire all of you, but in the meantime, maybe they think they can, but you do have more power than you think, because if every doctor took some kind of stand, right? No, who cares for the patients? It's the doctors, right? If you show up in the emergency room and something, who do you need to see? A doctor. If you need surgery, who do you need to see? You guys. Right? So if
Exactly.
they don't have the bandwidth to get involved themselves, even having like a conversation with one of you to learn, like, even how they can support what you're doing, even if they don't have time to do anything on a grand scale on their own, or just knowing that you guys are out there trying to make things better, it gives us all hope.
Yeah.
So, Yeah. Well, thanks again for being my guest. I love this conversation. I can't wait to share it, and we're all going to make a difference together.
Agree.
Thanks for having us.
Yep. Thank you.
You're very welcome. And what I would also like to say is I'm having a physician retreat the fall of 2026, Columbus Day weekend next year. And I'm hoping to gather physicians, such as yourself. So we have a whole weekend to learn and talk and connect with each other. And if anyone is interested in sponsoring the physician retreat, a weekend to connect, empower, recharge, and celebrate, reach out. And in closing, to move the needle in healthcare, we all need to raise our voices and we all need to care about each other. We already know that doctors need to care about patients. Patients need to care about doctors too. So stand up, doctors, and let's stand up for doctors.
Thank you.
Thanks, Kim.
You're welcome.